Today, I'm joined by Neema Kaseje, who is a pediatric surgeon, public health specialist, and has had a sharp shift in trajectory through the pandemic, moving from pediatric focus to more a pandemic focus. She joined us today with an amazing virtual background. It looks almost like you're in, I don't know, Western Kenya along the banks of Lake Victoria.
Thank you so much, Thomas, for having me today. And thank you for that kind introduction. So yes, I'm calling in from Kisumu, Kenya, and Kisumu is right by Lake Victoria in Western Kenya.
It's a lovely background. So tell us about your transition with COVID. What sort of became what you were doing, and then what became your priorities as the pandemic broke out?
So when the pandemic broke out, I was actually in Liberia, Monrovia, Liberia, with Doctors Without Borders. I've been going there over the past years to build up pediatric surgical care in Liberia. And when COVID hit, we had to cancel all elective cases. We were only doing emergency cases. And we had to basically look at what resources we had, masks, oxygen, and all those things, and figure out how we were going to respond to COVID-19. During about, I would say, a few months after that, we also, as a surgical community, realized that surgical patients who contracted COVID did not do so well. And so when I put all those things together, and given the challenges, then I shifted more towards public health to contribute to the fight against COVID-19, so that we can build stronger systems that can later respond to any kind of health challenge, whether it's a pandemic, whether it's malaria, whether it's surgical diseases, and so forth. So that shift towards building health systems is what happened in the past year.
And what were some of the lessons that you learned in terms of that? I mean, certainly everybody faced these shortages of PPE. Everybody faced trying to figure out, what COVID is. But what I'm particularly interested in hearing, and what we've spoken about previously, is the community-based response, or what you found was most effective, and how that compares to other responses, both in Kenya and outside Kenya.
So when we started back almost a year ago, we started out with a baseline assessment of pandemic preparedness. And this was in Siaya, which is in rural Western Kenya. And we assessed how the community was dealing with the initial outbreak of COVID-19. So their understanding of the disease, their knowledge about preventive measures, their health behaviors, hand washing practices. Are they going to the market? Are they going to funerals? Are they going to weddings? So we did that baseline assessment just to see where our starting point was. And we did that again at the health system level to figure out how prepared we were. And we identified significant gaps. So for example, CI at that point only had 2 ventilators for a population of 1 million. The good news, however, was that we still had essential health services that were still available and being provided. But the key message following that baseline assessment was that there was a need for training, both at the community level, in terms of raising awareness and in terms of making sure everyone was doing their part to prevent COVID-19. And also we figured out that at the health system level, we had significant challenges in terms of ventilators, oxygen, and the training of healthcare workers. So what emerged as the main strategy for CIA was prevention, and prevention that was going to be community-based, because with 2 ventilators, there wasn't much I or other healthcare workers could do at the health system level.
So basically, due to the limitations of equipment, it was very clear that this was not a management of the disease. It was more prevention. Prevention is the only strategy possible.
it was the only strategy that would lead to lives saved. Because of course we could have also tried to get as many ventilators as we could, and I think many countries did that. Trying to really strengthen the health system with ventilators, with CT scans, with oxygen, and so forth. But with the resources that we had, we couldn't do that fast enough. So then we just decided, okay, this is going to be a community-based approach, and we're going to maximize prevention at the community level. And at the health facility level, we're also going to maximize prevention by making sure that there was meticulous infection prevention and control. So anytime there was a possible case, they were separated from others who were coming for routine health services. We made sure that all healthcare workers had PPE. Because as a healthcare worker, we have a huge network. We can infect a lot of people. We can infect our family members, our patients, our colleagues. And so it's critical that healthcare workers are protected and that they have the proper PPE. So just to give you more detail in terms of that community-based approach, we trained and mentored more than 1,300 community health workers. And they in turn did door-to-door household visits to figure out, do the households have hand washing facilities? Do they have fever? So we were able to determine the baseline prevalence of fever, which could be a sign of COVID-19 and of course of other diseases, but it was a proxy measure for community transmission. We also looked at their behavior, and we also looked at, well, what are their thoughts about home-based care, and do they know how to take care of some family member who has COVID-19? So we went all through those key concepts about prevention, really about prevention, and then also teaching them about how to care for a patient or a family member with COVID-19 in a safe way. So things like don't share utensils, make sure you're washing your hands when you come in to see them and when you leave. Make sure both of you are wearing a mask, so both the patient and the family member. So we went through all of those key concepts to maximize prevention. And at the health system level, we also made sure that the healthcare workers were trained up, because COVID-19 was a new disease. And so we made sure they were trained up and they knew how to diagnose it, how to manage it, and that's how we started, and that's how we've been proceeding with the pandemic with very encouraging results so far.
So what was the reaction to this approach, and what were the elements that you were surprised at how difficult they were, or surprised how what strong impact they had?
So what was really striking was this concept of social capital, and everyone still really cares about their neighbors, and that actually made contact tracing very, very easy because everyone knows when you went to the market, everyone checks in on everyone else. And everyone wears a mask because in terms of how the community functions is not from an individualistic point of view, but it's more of okay, we as a community, this is what we're going to do. And this is going to be our approach to COVID-19. And this is how we're going to make sure that everyone is cared for. So I think that was a distinct advantage when it comes to the pandemic response in sub-Saharan Africa and in Kenya, which may not be the case in other places. In terms of challenges, I think what was most challenging is that social aspect and human aspect of behavior. So I can give you an example. Here culturally, it's very difficult to tell someone they can't go to the funeral. It's almost, and they're likely they will still go actually. And so initially that was a bit frustrating because you're saying you're going into a place where there are many people. maybe not everyone's wearing a mask, maybe they don't have enough hand washing facilities. So knowing that they would still go anyway, which was the case. So the next step that we took was to basically figure out, well, okay, if you're going to do it, this is how to do it safely, and making sure that everyone is engaged in that process so that it's not a top-down decision and you have to follow. And if you don't follow, you'll face consequences. But it's more, okay, I understand that you really, really want to go to this funeral of your very close friend or family member. But if you do go, please make sure that you're wearing a mask and the people around you are wearing a mask. And so figuring out that, okay, this is going to happen, but let's do it safely. And I think, I don't think that challenge is specific to CIA. I think it's actually a global challenge. We're really having a hard time, balancing some of those strict public health measures and human beings as social beings. And yeah, we need that human contact. We need to, if we lose a loved one, we need that time to grieve, and we need to be around other people. So balancing those things, because in the long run, we need everyone together. And so if we create divisions, then it will make things difficult in the long run, because this is going to last for a while, I think.
So if you were to go back in time, and from what you've learned in this process, what advice would you give yourself 1 year ago today?
So I think I would tell myself to be more patient, because as surgeons, we were not known for being the most patient of people. And when working with communities, you do need that patience. You do need that patience. You need to listen. You need to figure out the whys. Why is it happening this way? Why are they doing it this way? And then working together to come to a solution. Because actually, when you have everyone together with you, when the community is with you, you can achieve anything. Actually, it's a powerful mechanism for getting things done and doing it in a sustainable way.
And what has been the impact within Kenya relatively, and within comparative with other interventions, and what are lessons that can be taken out of it?
And so when we compared CIA to neighboring counties, Kenya is organized in 47 counties. We saw an 8-fold reduction in the number of COVID-19 cases. We also saw a reduction in diarrheal cases, in respiratory infections not related to COVID-19 because of improved hand hygiene. When we did a quick assessment of vaccine acceptance, it was more than 90%, because we had created that system where we were closely connected with every single household, and they had access to reliable information. And so they also trusted the health facilities and continued to use services. And they trusted the whole vaccine rollout process. So those were key. In addition to that, as I mentioned before, they still trust the community, and so they continue to use services. So for example, women continue to deliver in health facilities, which was not the case, for example, in Liberia during the Ebola outbreak, because usually when there's an outbreak, immediately people fear going to the health facilities and they would rather stay home. So we did not see that. And those are key lessons that could be learned, not only for Sub-Saharan Africa, but for the rest of the world. So
it sounds to me like a lot of it came down to trust, and
trust, yes,
building that trust in the relationship with the community. Yeah. And once you've established that, you have something ongoing that becomes almost an asset in that relationship.
Yeah. And so trust is key. And maintaining that trust over time is also critical. And as they say, you know, it takes a long time to build trust, and you can lose it in a second. But I think that's the most valuable resource out of this whole process. So in terms of next steps, you know, community-based healthcare is actually a very common strategy in sub-Saharan Africa for delivering essential health services. So all the way from Sudan all the way to Mozambique, there is community-based healthcare, and all the way to the west to Senegal. And so what we are hoping now as next steps is to scale up this intervention, especially considering the disparities in vaccine access. We really want to maximize these non-pharmaceutical interventions as we wait for vaccines to come. And when the vaccines do come, it will enhance that package and not displace it, because with new variants, that's a whole nother challenge. But I think for now and for the foreseeable future, we really need to maximize, you know, mask wearing, hand washing, distancing, especially in contexts where the health systems are fragile and there is next to no access to vaccines.
Fascinating. So it sounds in a way like it's been a good crisis, obviously not a positive thing, but there have been positive things that have come out of it.
Yes.
And then, you know, I was really interested in how you're mentioning the impact it's had on other infectious diseases, diarrhea and others, which would have been more difficult to tackle if COVID hadn't arrived.
Yes, absolutely. And if we can say the good thing about COVID is that it really got everyone's attention on health. So although, yes, we are dealing with COVID-19, we're using it as an entry point to make sure that we are providing comprehensive health services. So as we talk about COVID-19, we want to also make sure the children are vaccinated. We want to make sure that pregnant women are going for prenatal care and are delivering in health facilities. So yes, COVID has been good in a way because it has focused everyone's attention on health, the disparities in access. And yes, we've used this opportunity to tackle COVID-19, but also to tackle other health outcomes that need to be improved.
Excellent. Thank you so much, and I hope the good work continues continues paying off in terms of the lack of infections.
Thank you so much, Thomas, for having me today, and it was a pleasure to share some of our share experience and share some of the results we've had so far. Thank you for having me.